afternoon, ladies and gentlemen, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your host, Mr. Stephen Samis, Vice President, Programs at the Canadian Foundation for Healthcare Improvement. Please go ahead, Mr. Samis.
Thank you. Hello and welcome to our Understanding the Lay of the Land, Assessing Organizational Improvement Capability on-call webinar for today. As you know, or if you don't know, CFHI is an improvement organization funded by the Government of Canada, and we are dedicated to collaborating with health system leaders to accelerate healthcare improvement for Canadians. We're delighted to have you on the call today, and today we expect to be joined by about 130 organizations from across the country. We're also pleased to be providing simultaneous interpretation of today's call for our Francophone audience across the country. Everyone, please take a moment to introduce yourselves in the chat box, along with where you're from, as I proceed to introduce today's speakers. We're really delighted today to have with us Denis Roy, Clinical Assistant Professor at the École de Santé Publique de l'Université de Montréal, and Associate Professor at the Université de Sherbrooke and McGill University in Quebec, as well as Jean-Louis Denis, Professor at the École Nationale d'Administration Publique in Montreal and Canada Research Chair in Health Governance and Transformation. Also joined here today by our CFHI staff member Claudia Amar, who's an improvement lead here with the Canadian Foundation for Healthcare Improvement. And as you heard, my name is Stephen Samis, Vice President of Programs here at CFHI. So here's what we're going to set out to do together today. We're going to start by understanding the key attributes of high-performing health systems and key change levers for accelerating healthcare improvement. We're going to share a case example from Quebec on how to initiate and sustain healthcare improvement and transformation. And we're going to learn how to assess organizational improvement capability by applying tools such as the CFHI's Accelerating Healthcare Improvement Assessment Tool. So before we get to the high-performing and successful organizations, let's just take a moment to talk about failure. No one sets out to fail, especially when we're trying to improve healthcare and improve the health of populations. But it happens. And it happens so much that someone studied it. And here's what they found. Sometimes it's a failure in process. Improvement is complex. The change process is messy and context matters, which is why small-scale tests of change are so important. Sometimes it's a failure in measurement. What we set out to do and the measures we put in place to evaluate the difference it makes don't align. And sometimes we don't think about what we need to measure effectively at the outset. Sometimes it's a failure of the proposed improvement itself. Maybe we're still beta testing an innovation and we're really not ready for prime time. We talk a lot about teamwork, but we often create unrealistic expectations for ourselves, relegating improvement to an off-the-side-of-the-desk project. And in fact, the U.S. Institute of Medicine has said it usually takes about 17 years to push best practice into common clinical practice. We don't think it needs to take that long, particularly in the area of healthcare improvement, but we do believe in setting realistic goals with small-scale tests of change for what's possible in, say, 30 days, 90 days, 120 days, and so on, so we don't burn ourselves out at the planning stage. And we also know it's really important to work as a team and share the workload. That really helps in accelerating improvement initiatives. We know fundamentally that planning, after all, is just the beginning of improvement. And that's why we're going to listen to the two interesting case studies from Quebec today. So I'm now going to turn it over to Jean-Louis Denis, who will describe how our 6 levers for accelerating healthcare improvement came to fruition.
Okay, thank you, Stephen. Bonjour. They asked me to speak in English, so you will get a big accent, but I hope it will be clear. I guess the main theme of the webinar today is, I'm using the last book by Lazar on difficulties in achieving healthcare reform in Canada, and they use the term paradigm freeze, and I guess today what we try to learn from various experiences how we can unpack this paradigm freeze and move forward. And one of the idea we have to do this is looking at specific levers, how we achieve change in healthcare system. And the foundation was very supportive in the last 5 years to generate, in my view, a good stock of work around high-performing healthcare system, what we can learn from the experience of various healthcare systems in Canada in different provinces about bringing about change and so on. So I will move to the next slide, and I'm sorry, but I don't have the arrows to move. Okay, thank you. And initially, the foundation focused on the research capacities of organization. How healthcare organization can use evidence in their day-to-day life and improvement effort. And this is shown in these two papers. And next slide, please. And then the foundation moved progressively to a model that have two main pillars. One is developing improvement capacity, and this is the basic hypothesis, is if it's difficult to achieve big bang reform, let's not just fall in inertia, and let's try to find resources and ability to improve in our own delivery and policy context. So it's an optimistic hypothesis, but we believe strongly that there is a space in the system that we don't exploit enough to bring about improvement, and there are evidence around this. So building improvement capacity, and the second aspect is supporting people in their improvement journey. It's very often we underestimate what people, organizations have to learn to practice differently and deliver better care. Next slide, please. Now we move to I call it the model, and this is with humility based on a paper that we did in 2011 at the request by the foundation to look at what we can learn from 10 years of attempt to improve the healthcare system in the difference in province in Canada since the 2004 Canadian Health Accord. And we start to review two things, existing evidence in the literature and set of policy report and gray literature on how each of these systems did during that period, and we discuss a lot with different policymakers on the way. And we arrive at these 6 levers that I will briefly describe one by one, and each lever is a possible entry point to bring about change and improvement, but a single lever is not sufficient. A system or organization have to combine them through time to achieve a greater improvement. So next slide, please. Oh, okay, I'm good now. So the first is really focusing on population health need. And I would be brief on this, but it's the landing point of the model, and it's based on the following observation. Despite many years of policy discourse, new policy, efforts by provider to increase the role of primary care and deliver better care for chronic disease patients, for example, or mental health patients. It's difficult to do it because we have difficulty of reallocating healthcare resources in the system. And it's a kind of gridlock in the system, and in the paper we call it a kind of political economy. Despite goal to reinforce primary care and reinforce sector of care where we have major care deficit, we tend to replicate our ways of doing things because we have difficulties in moving resources and some priorities, around new priorities. So in this process, we had to think about other levers, because if you say, I have difficulty in allocating resources and stop there, you will not be able to achieve any kind of improvement. So one of the key things is that we got immersed in the work on healthcare network, engagement and leadership of clinical leaders to improve care. And clearly, any system that achieves or organization that achieves significant improvement rely on a strong culture of improvement, and this culture of improvement must be adopted and co-developed by professionals who deliver care. So to say it more brutally, a real reform in healthcare is a reform that impacts on the way that people deliver care and on patient or user experience. So that's the first lever. The second lever, the other lever is really renovating our organizational arrangement. And we know that to achieve better integration of care, we need to be able to implement effective healthcare network. The governance of this is a challenge. The ability to coordinate expertise and resources across organization is a challenge, but it's possible to do so. Another aspect of this is investing more in team-based organization, and the work on interprofessional collaboration is a positive symptom of this. We need to be stronger in delivering care in teams. Another lever is the broader environment, and as you know, and because we have to move fast, we have to take very more explicit example, but one of the often example here is the incentive and the way we pay physicians. That's a policy issue. Another policy issue is how you provide funding to healthcare organizations. Are there elements of quality and performance that enter the equation here? So again, to be in a better position to achieve improvement, you need a policy environment that is more aligned with what you try to achieve in the organization. And the last two levers are what we call countervailing power. Because of some inertia in the system, some difficulty in reallocating resources, we start to look at alternative levers, and this is, I guess people across Canada did not get more interested in patient involvement in the design of care or patient-centered care just at random. It is because provider and organization sees in this kind of involvement a way to change the conversation within the context of delivering care. So that's why we call it countervailing power. And same thing for evidence. The growing interest around using evidence from research-based evidence to think about new model of care, governance, performance management, best practice are also a way to change the conversation and to enter a new person around the table that I call evidence. And the conjunction of patient-citizen involvement, depending the context, with evidence, help provider, organization, decision maker, and policy maker to value change in the system. So I finish now. Thank you.
That's great. Thank you, Jean-Louis, and thank you for your work on that has really helped us to build the knowledge base on the theories of change, the levers that facilitate improvement, and the characteristics of high-performing health systems. These are the kinds of things we need to be keeping in mind as we do our small tests of change and then replicate those cycles in order to achieve that broader improvement that we're trying to achieve for all Canadians. So thank you so much. Just a reminder to participants that should you have any questions as they come up, please don't hesitate to type them in the chat box. We're going to get to them later in the call, but we're happy to start collecting them now. And now it's my pleasure to turn it over to Denis, who will share with us the case study from Quebec.
Thanks, Stephen. Hello, everybody. So I will try to summarize 10 years of work really in 10 minutes. So that's quite a significant challenge for me. Just as an intro, this very strong quote from Edgar Morin, the great philosopher, who mentioned that nothing important is ever defined by its boundaries. And that was the intent behind the radical change that we experimented in since 2004. It really was the idea to try to build networks, try to build service integration, broadly speaking, for the health provision, but also for the health capacity and health improvement overall at the population level. So it's really quite a challenge that was envisioned. It was, as you can see on the slide, based on restructuring first. There was a merger, the RCLSC, the primary care community service capacity, with acute hospital and our long-term care facilities being merged at the local level, 95 such units across the province and within 18 regions. So it's a fairly considerable restructuring effort. But in addition to that, these new C3S, as we used to call them, were mandated by law to mobilize their partners in the local jurisdiction so that they can build this integrated network of providers and health promoters, largely speaking. So you can see the physicians and the pharmacies and the usual health partners, but also the municipalities, education, social economy. So it was broader than the actual service provision per se. So it was a very strong proposal, and it was quite a challenge to implement. But I'd just like to, at this point, review, using the model, the six levers model, review the progress and share thoughts on maybe some of the key observations that we can derive from this work. More broadly, before we enter the levers per se, I think, observed genuine progress. The vision was very strong. This vision of serving a broad population base, uniting forces, and merging our efforts in order to come up with a meaningful population level change. I think it's quite a strong proposal, and people bought into this idea, and it was very fascinating to observe the mobilization that was very present across the province. We observed also increased cooperation between local stakeholders, sectoral and intersectoral. We've observed also, and it's been measured objectively, some progress in terms of health, particularly some progress in chronic disease management. And also we've observed a better service delivery infrastructure, some intersectoral collaborations that were new, particularly with municipalities in the education sector, and also some significant improvement in terms of the senior care integration. So it was much more clinical at this point, but still the social services were key in helping us accomplish this. But we still are facing persisting issues. Jean-Louis has alluded to the fact that reallocation is a tough challenge to come up with. Frontline services remain a challenge. Appropriateness of use of emergency care though some improvement have been observed, remains a system challenge as well. The high users, the frequent users, we're currently devoting major effort in this area, building on CFHI's partnership, but also IHI is helping us do that better. But we've, again, some interesting cases of progress that we've observed. End-of-life care has not been addressed significantly, and it remains something that's a great unmet need and as an appropriateness issue that we face at the system level. And although we've done not that a bad job in terms of dealing with the social inequalities, the gap has increased, but to a lesser extent maybe than in other provinces in Canada and certainly internationally. But still, we can dig a bit further and use the levers now to examine more specifically some of the progress that we've accomplished. The first lever, the population needs stuff. It's a bit technical here, but what the key message here is that we've learned how to better use the indicators, the population level indicators, to really assess needs, put up our priorities, establish our priorities, and build programs that are more appropriately designed to meet their needs. Obviously, still some work to do, but it's probably the major progress that can be observed at the system level, in my view. In terms of the frontline managers and providers, I will start with managers. The middle managers are faced with a number of competing models to help them guide their improvement efforts, just a subset of them. And this idea of population-based reform was another that would add to this broad array of already available paradigms and models. So in some way, I think they were lost. What's the key element for this population responsibility, as we call it in French, the responsabilité populationnelle, this population orientation, so that we could build networks accountable for populations? And a recent survey reported in the Point en Administration de la Santé explained that it's still a fact of life. For managers, reform is complex to understand, and although this population orientation is deemed important, is still inspiring, it is often perceived as ambiguous, and people are trying to understand the logic model to accomplish it, actually. So I think one of the learning is that we've been facing a challenge in translating in operational terms the purpose of this idea of being responsible for a population as a health sector. I think we need to be more explicit, probably, to help managers get on board and actually experiment and test their ideas to better do that. In terms of the medical services, particularly the primary care frontline medical services, unfortunately there was a competing reform at the same time of the network were implemented. There was this Groupe de Médecine de Famille reform that was not centrally aligned with the idea of networks. So we had to manage a concurrent reform for some reason. And this reform was led to some improvement. The Groupe de Médecine de Famille reform led to some improvement, but it remained mostly focused on the medical practice, much more than partnerships and collaborative work. And it was also strongly influenced by the national leadership, much more than by the local people. So in some ways, it was a concurrent reform, and we may have missed an important rendezvous in aligning the two reforms so that we would reinforce as well the care integration at the population level and the primary care offer. The evidence, we did well, I think. We did most of what we could from the extra program. I think we have participated very strongly to this. We had some innovations. The Montérégie project I had the chance to be involved in led us to some recognition. Montreal did some very well also in terms of using indicators as well as the public health sector. And we came up with some improvement in terms of organizing what we know on the best practice, taking stock of contextual stuff. So it was not purely scientific work, but it supplied best practice materials, and we collaborated with Accreditation Canada in order to do that. We did some progress as well on assessing performance at the system level and using population models to do that. Also, we've observed over the 10 years maturation of two big public organizations involved in knowledge management that is designed at supporting decision making, and I think this has provided some meaningful input as well. In terms of engaging patients, we've done some progress. The original push was at the central level, but the Citizens Forum at the Health Commissioner, Health and Welfare Commissioner was an innovation in itself, and it led to very great insights in terms of taking stock again of the patient perspective and citizens' perspective on the planning and the priority setting and the identification of big issues. At the local level, the work was mostly designed at failures, concerning the complaints, what didn't work, what could be improved or should be improved, but it was maybe less aligned with the patient engagement movement that we've seen internationally. But at University of Montreal, there was this patient partner innovation, what is referred to, I think, as the Montreal model, which is much more aligned with this idea of patient engagement, patient being actively participating in the actual building of the care plan. Organizational capacity, again, we did some interesting progress. The IPCDC, I won't go into the acronym, but it's really a consortium where many partners merged their efforts to better enable change to happen and accelerate improvement at the system level. I think it enabled us to come up with e-health programs, some guides, tools for practitioners, self-assessment tools, virtual office that was, I think, very interesting and still very, very much used. And I think the top of this work was the process consulting that we developed in order to enable change management to better occur within networks and lead us to innovation in terms of the way we would program things and put our act together in order to better integrate services. We call this in French accompagnement. I think this notion of accompagnement has a great future ahead, and we may be able to discuss it further if you need to do so. Concurrently, we had also a minister who favored pretty much lean processes, and he was very much pushing it for his mandate of 5 years. So we were able to add some significant, as I think is being attempted now in Saskatchewan, to come up with the lean process mastery within organization, and it led to some improvement in terms of emergency operating rooms and imaging services, but less success probably with more complex process having to do with chronic disease management, unfortunately. And lastly, in terms of the supporting policy, I think the challenge that we faced in that context was to merge really, or to synergize the professional logic with this public administration logic that was guiding the reform. It was a top-down reform mandated by law with lots of restructuring. So it was really the public agenda, public administration agenda was very strong, and sometimes we were trying to find a way, a space for some professional bottom-up leadership. And I think that has not been as successful as it could have been, and overall, I think the top-down logic largely dominated. And this is a difficult piece, obviously, and it seems to be a recurrent pattern across Canada, as I gather. At the point I was preparing my slides, we were discussing a new law. I will do to that before concluding, but I think we had a J-curve, and it's important that to observe that over the 10 years, the first 2-3 years, what were really a loss in performance at the system level, most probably. Obviously, there was not avoidable mortality or very important signs of failure, but we all experienced that J-curve phenomenon. But I think over the years, it led to real improvement over the baseline, and we were, as a group, pretty confident that we were on the good direction. But political people and elected officials decided that we wanted more and more quickly. So the Bill 10 that was recently voted by the National Assembly invites us really to pursue and simplify maybe governance and simplify the models that we're using, and build with a more direct alignment on the ministry intent and goals. And we're currently embarking on a new reform journey. We will have 26 centres intégrés de santé et de services sociaux responsible of populations that are still locally or regionally defined, if you will. And I think it will be a challenge in terms of restructuring again, but we know how to do this to some extent, and hopefully will better align for the next steps this professional culture and leadership and the capacity to build on the clinical disciplines and keep this alignment with the public administration agenda and particularly the value for money agenda and the cost containment, and better take stock of all these ideas and better serve overall populations with an integrated offer of services. So that summarizes what I had to say, maybe too much. I'm sorry for the tempo of it, but it was 10 years in 10 minutes, and hopefully we'll have some time to share on the learnings in more details in a few minutes. Thanks.
Merci, Denis, and thank you for sharing Quebec's 10-year journey on taking a very sophisticated approach to improving healthcare using a population health approach, and doing that through the development of collaboration networks as well as careful evaluation and reflection, which really is the essence of a PDSA approach, which is to plan, to do, to study, and to act. So, congratulations to the work that you've undertaken to date. Thank you for sharing it with us so succinctly and so well in such a short period of time. It's now my pleasure to turn it over to CFHI's own Claudia Marr, who's going to describe what the CFHI assessment tool entails.
Thank you, Stephen. So we just heard a really great example of how these levers apply to the Quebec context. And some of you might be asking yourselves, how can we assess our current capacity to not only undertake, but to sustain and spread healthcare improvement in our organization? And so we wanted to develop a simple tool that could support organizations in doing this, which led us to wonder how organizations can assess their readiness to embark on an improvement journey. So the tool has been a few years in the making. We first started off by reviewing various improvement frameworks, such as the one from the Institute for Healthcare Improvement, or IHI, the one from Robert Wood Johnson Foundation, and many others, to assess which one best fit our mandate. After developing our first version, we asked 11 external reviewers to provide feedback on the tool, which we then incorporated. 3 reviewers are health executives, 2 are physicians, and 6 are policy specialists. And of course, there was also a thorough internal review process that we've conducted. Last January, we piloted the tool with 3 Canadian healthcare systems, 2 of which were in Alberta, 1 in New Brunswick. We collected their feedback and incorporated it into the tool. And we used a very similar approach again last May when we tested the tool with 2 organizations from the IHI Triple Aim Improvement Community. One was based in Newfoundland and the other in Ontario, so we had a pretty good coverage across the country for these pilots. And so here we are now. We decided to make this tool freely available on our website, as we hope that organizations will download it, use it, and provide us with feedback on how to make it better. And so once you download the tool, you'll receive an email shortly after containing a link with a survey, and we highly encourage you to complete that survey, as we are looking forward to receiving that feedback. So moving on to the next slide then. So briefly, what does it include? It explains the why, so why we, CFHI, developed this tool, why organizations should use it, the 6 levers for healthcare improvement, which Jean-Louis walked us through really well a couple of minutes ago, how to use the tool, a better rating system, and here we really emphasize that this isn't about scoring yourself necessarily, it's more about being able to discuss as a team where you have strengths and areas you may need to work on. There's also the assessment tool portion, of course, which includes statements that align with each of the 6 levers, and the discussion guide, which I'll come back to in a few minutes. So why use it? Well, because it can be difficult to know as an organization what needs to be fixed when you're too close to the problem. You alone can't necessarily make those decisions, so you need to involve those who are not only responsible for the management, but the financing and delivery of care, as you all bring a very different and important perspective. Our hope is that this tool can help you formulate a plan for improving the care you deliver in your organization by not only identifying your improvement strengths and areas in need of improvement, although that is a good start. It's also to help you understand your current capacity to identify those improvement efforts and to amplify them, and of course to take next steps for improvement. And so moving on to the next slide then, to give you an idea of what the tool entails, we have a polling exercise for you that's based on our population needs lever. Our poll addresses this question overall: how do leaders develop whole population approaches to care while still recognizing the individual needs of patients and their families? So what we'll do now is that we have 5 polling questions for you, all about the precursors to population management, which we'd like you to answer. And note that these will be listed in both French and English, and Sheena, our producer of the show, is actually pulling them up right now. So here's what's going to happen. To the best of your ability, answering 1 for strongly disagree, 2 for disagree, 3 for neither agree nor disagree, 4 for agree, and 5 for strongly agree. And of course, if you don't know how to respond to a statement, you can indicate so and move on to the next statement. Consider the following statements. 1, we understand the population we serve. 2, we have health system goals which take into account population health needs. 3, we monitor our performance against our population health goals. 4, we address the varying needs of our patient population. And 5, we are formally accountable for aligning our programs and services with population health needs. So we'll give you a minute to answer those. And in the meantime, since we have a little bit of time, I was wondering if, Denis, you could share some of your reflections on how you see these statements aligning with what you described earlier.
Thanks, Claudia. Just start with the, we understand the population we serve, again, referring to the case study that I just summarized for you. I think I would think that it's something that we did pretty well. It's still incomplete, but I would be certainly plutôt en accord, totalement en accord. Je sais pas trop, mais en tout cas, moi je mettrais un 4 for this, based on what we did. The second one, in terms of health systems goal, which take into account population health needs, I think that's something we lack, actually. We have health system productivity objectives that are fairly sophisticated, but are basically built on the client logic, much more than the population, overall whole population logic. And for this, I think we would still benefit from population-based quality goals, and maybe, why not, population-based avoidable morbidity, mortality goals, or something like that. I think it would be, so for these reasons, I would rate us as a 2 or something. We monitor our performance against our population health goals. Obviously, it speaks to what I just mentioned. We monitor our performance, that's true, but we use productivity indicators by and large, and for that reason I think it doesn't serve as well as it could the whole population health need agenda. In terms of addressing the varying needs of the population, I think this we do better. We have a fairly comprehensive supply of services. We have programs specifically designed for different clienteles, and it helps us remind us that we have to serve and address appropriately the different segments of the population. So I would be more inclined to use a 4 or something in this area, although this could be debated. And we are formally accountable for aligning our programs and services with population health needs. This alignment stuff is really a difficult one. I fully subscribe to Jean-Louis' point of view. I think that's what we need to work for the next years, because we tend to build what we do on the past rather than the future or at least present needs. We have difficulty realigning. We have difficulties really optimizing what we have in order to make it evolve structurally and functionally to better adapt to the needs that we identify. So for this reason, I think this last one, I think, is a 2 or a 3, but it's certainly not more than that in my book. So just, that's the type of use of these questions that I was inclined to do. I don't know if it's the appropriate manner, but I'd like to hear your comments on this.
Great. Well, no, that was fantastic and very helpful. And it seems like most respondents have, answered similar things, maybe with the exception of the second question about having health systems goals. But overall, people seem to be agreeing about most of these, and not surprisingly about in regards to the monitoring our performance, that always seems to be a little bit trickier and more challenging. So likely more work can be done in this area, and of course aligning that with the accountability aspect. So, I mean, do you see, based on what you're seeing across on the screen, do you have any further reflections?
I think just on the health system goals, I think it would in itself be a very interesting point to explore and discuss in more details. But I think I've observed, particularly in the pay-for-performance schemes internationally, there's some very interesting thoughts that could lead us to improvements. I think also that in Ontario, you've been more successful than we did in Quebec in terms of maybe more creative in terms of using population-based health indicators in order to inform accountability schemes. But I would be really fascinated by more discussion of this topic, which is a very important element to anchor the health reform in my view.
Great, fantastic. And maybe I'll prompt Jean-Louis. I don't know if your line has been unmuted, but I would be curious to know what you think about all of what you're seeing on screen.
Do you hear me?
Yes, I do.
Okay. Well, maybe just a brief comment. I think all the very nice case that Denis present and the response to the different questions is, I guess what we observe is there is a difference in reorganizing a system versus changing its logic, how we approach problem priority, and how we generate capacity to respond to these new, in quotation, new priority. And what strikes me when we look at different healthcare system and organization is that it's not that they lack resources necessarily. It can be tough in terms of level of resources, but overall, it's a system where we put a lot of resources and we maintain through time a lot of deficit in care. And I think this is strongly related to the kind of logic that Denis referred to. How can we get organized to do things differently at a sufficient scale that we will respond better to different needs. And I think that that's what people refer to when they say a cultural change. I think it's all these aspects that come into play when we try to move these systems not around other objectives, but to incorporate other objectives and goals. That's it.
Great. Thank you so much, both Denis and Jean-Louis and Claudia, all of you, for the discussion so far. Just again, a call from our audience. If you have any questions, please type them into the chat box. We look forward to any thoughts you might have, any questions, any comments, any reflections as you went through the survey exercise. I guess in the interim, I would ask both, perhaps Denis, you talked about the new bill in Quebec and the changes that are coming. What do you see with reorganization will be some of the benefits and challenges, some of the things that you will have to really pay attention to keep the momentum going?
Certainly keeping the population focus. People are very much concerned with the restructuring and finding your marks really in this new context. But if we are able to maintain a strong population focus, it may lead us to a simpler system to work with. Just remind that in Quebec we had a 3-level governance scheme: the national, provincial, the regional. We had 18, and local 95, which is a fairly busy governance scheme overall. So I think what the new model will have a strong central leadership, a governance scheme that will also build on a lesser number of jurisdictions. There are 26 territorially, geographically defined centers in charge of the whole population, and we have also university networks as well. So I think that simplified the governance scheme that will maybe contribute to alignment, as long as we can really reflect the 6 levers model very fully, so to take advantage of what we know in terms of successful reforms, and trying to reinvent the implementation scheme so that it's enabled through the implementation model that we adopt. And this is a source of concern. People fear that a strong top-down leadership insensitive to local realities, and that's a real challenge. It may be the case, but it doesn't have to be. And if we are skillful enough, we may input these concerns. You know, the local information, the local realities, also the citizens' point of view, to use it as a countervailing power, as Jean-Louis mentioned, in order to reestablish a balance so that the planning is much more comprehensive and aligned with population needs.
Excellent. Thank you, Denis. I think that maintaining that focus on the health of populations, on population health, on the local populations that are served, and the sort of the institutionalization of that thinking in Quebec should see people well through the change process. I think that's very important. And I noticed that from the participants on the call, there's a few people online today who are part of our collaborative on patient engagement, and that is a very, very important counterbalance to all of this, is engaging patients and families much more actively in the governance, the management, and the redesign of healthcare. So again, as you described it well, I think, as a countervailing factor. Back over to Claudia now to talk a little bit more about the discussion guide and to wrap us up on the tool.
Great, yeah. So I mentioned this earlier, but the tool, once you've had a chance to complete it, comes to this section, and it culminates into a discussion guide. And that guide, in many ways, is probably the most important part of the tool. It enables your team to sit down and review the results after having completed it, and it helps you determine your areas of strength as well as your areas you may need to improve on. So you might start with population needs, but you might start with another lever. And also determine, and ultimately you might leave the room with a priority and an objective. So we highly encourage you to download the free tool on our website and to provide us with feedback. So I'll turn it back to Stephen and be happy to take any questions if there are, or just to move on to next steps.
That's great. Thank you, Claudia. I'm not seeing any questions coming in or any comments coming at this point. Please do feel free to send us any that you have, and as we start to wrap the call, we will read them out. But in any case, we do welcome your feedback. And if you do have any questions, we will ask the presenters to respond to you after the webinar. But again, thanks again to all of our three presenters for today's call. For those of you online, we hope you will join us again on one of our upcoming on-call webinars. On March 16th, if you're really interested in the EPCDC work and the focus on population-based responsibility in Quebec, now the good news is that we have an informational webinar, Population Management by Design in Policy and Practice, featuring Armand Boudreau, Denis Roy, and Jean Rochon. Then on all of those speakers will go into the much more detail about the EPCDC process, as well as that focus on population-based responsibility that Denis has been describing in Quebec. On April 1st, we're going to launch the first of a four-part webinar series entitled In Pursuit of a Chronic Care System. How are we meeting people where they are? And again, this follows very much on understanding your population and meeting their needs, particularly as our populations age and as more and more Canadians are living with complex chronic conditions. And for that call, we're going to be joined by Dr. Jeffrey Turnbull from the Ottawa Hospital and Dr. Claire Liddy from Ottawa for part one. And they're going to focus on shifting culture, shifting care, from usual care to chronic care. So for more information about these upcoming webinar series, as well as to register and the full on-call lineup, please visit our website, www.cfhi-fcas.ca/on-call. And finally, before you sign off today, we really highly encourage you to complete our brief survey, which you can access directly from this slide. This really helps us to understand how these webinars are meeting the needs of the audiences that are signing up for them, as well as helps us program future webinars. Finally, one last chance to thank our three presenters today and to thank all of you for joining us online. We're going to end the call a little bit early today. We thank you for joining us, and this concludes our session.